Before we, hopefully everybody can see the first layer. Before we move on, one of the things as a pathologist, as an active, pathologist, I appreciate sometimes that it's challenging to be able to understand, when to apply cancer protocols and really a lot of the staging things that we talk about with TNM classification. It's usually it's pretty straightforward when you're talking about one resection and applying it in that regard. But when you start talking about stage procedures or you start talking about multiple procedures, there can be a lot of challenges with that, and appreciate it. I encounter those challenges as well in my practice, and things I do as the vice chair of the CAP Cancer Committee. One of the roles is to sometimes field questions, from our customers in terms of of applying the cancer protocols, and I'll take a look at these questions, and I'll sit there and scratch my head and think, I hadn't thought about this. So there's more to be applied to these, and you really got to kind of think these through. And on the CAP Cancer Committee, when we talk through cases, a lot of times the discussion is very lively because there's no one right answer to doing things. So with I need to do a few disclosure things before we start the.
Dr. Baker, it's Dana again. We can't see your slides, so I think you just have to share your desktop. I think.
Okay.
And then we'll see them.
Okay. Hang on one sec.
Problem.
Sorry about that. That's how we had this. Oh, there it is. Okay. Now, can you see?
Perfect. Thank you.
Okay. So now we're going to go back to the cover slide there. So anyways, before we start, one of the things I need to do is go through a few disclosure information slides. Now, I have no financial relationships to disclose for this briefing, and I will not discuss off-label use or investigational use in a presentation. And the United States Army and the Department of Defense and the United States government, I need to let you know that these private assertions, this does not reflect the official policy of the Department of Defense. When we talk about staging tumors, especially when we talk about stage procedures or multiple procedures, I think applying the rules of for staging, you really have to kind of understand the TNM classification system and understand the rules. So every time we get a challenging question about staging or applying the CAP cancer protocols, I always go back to the general rules of TNM classification. And so, it means pulling out the AJCC staging manual and the CAP cancer protocols, taking a look at them, and really kind of reminding myself of what the general rules are. And so that's the first thing we're going to talk about is TNM classification, kind of an understanding of the general rules and how to apply those. As I said, the CAP cancer protocols, understanding how to apply those too. What are the minimum requirements in terms of using the CAP cancer protocols, and then what are more ways to use the CAP cancer protocols. Talk about that a little bit, and move on to challenges with staging procedures in which there are multiple surgeries, and then we'll do a couple of scenarios, and these scenarios are based on these were scenarios that were provided to me by you all last month. So these are actually real life scenarios, and so I'm going to go ahead and answer, or at least my opinion about how to approach these scenarios. Now, things you'll realize is that a lot of things, there's no one right answer, and so you're gonna get my opinion on these, but there actually may be a better way to do these things. So I look forward to the question and answer period, and seeing what type of discussion we can have, and what type of questions are out there. So the first we're going to do is we're going to just provide an overview of staging, and I mean, a couple things with that is, we talk about the T&M classification system. That's the one we're most familiar with, and we all know that there are three main staging systems that are out there being used. There's the summary stage, collaborative stage, and then T&M classification system. Most of us are familiar with the T&M classification system. That's the one that's the basis of the AJCC staging manual. So that's what we're going to really talk about. Differences between those three staging systems are really based on the objectives of the end users for those systems. Whether it's being used for clinical care or for population surveillance. So those classification systems or staging systems has a little bit of a different slant. But we'll ignore the other two and just talk about T&M classification at this point. So the T&M classification, as most of you know, is based on the anatomic extent of disease. And so that's really the core of the T&M classification system. And historically, if you look back at the T&M classification, that's all there was. It was solely based on anatomic extent of disease. So when you look at the T component, the N component, the M component, all anatomic extent of disease. Over decade plus, we've obviously identified other information that's useful for prognosis as well as treatment. Whether you're talking about clinical data or what we always think of with molecular data, for example, laboratory data, for example, with PSAs, in prostate cancer and things like that, and those are being incorporated into the T&M classification system. So it's really the way to think of this is that the core of the T&M classification system is the anatomic extent of disease, and actually look at the staging part of that, stage 1, 2, 3, 4. Other diagnostic information can influence that. It can inform that. And a good example is prostate cancer with PSA. So PSA can actually change the stage grouping for prostate cancer based on the level of PSA. And then, so if you look at the cancer protocol, you'll actually see that as a part of it. The T classification system, in terms of clinical utility, I really think of four things that in terms of clinical utility. Number one, the T&M classification system has been shown over and over again to be a valid process for prognosis in cancer, and also allowing for uniform assessment for treatment purposes. And that's typically what we think of, when classifying cancers. That's the big thing we think of. A second that we're seeing though often now is that there's all these online databases that have predict models for whatever cancer you're talking about, whether it's prostate or whatever, and these are being incorporated into clinical use more and more. And what informs us, the data that's being used for these predictive models is actually from the T&M classification system. So the information that we put into T&M classification is actually used for that. T&M classification is also used for comparative information for population surveillance at the tumor registry and higher levels, so at the state level, at the national level. And then, what we're more and more now with healthcare organizations, individual hospitals, healthcare organizations is the use of comparative effectiveness research to help to inform or change their daily practice within that hospital or within that organization. So those are really the four things I think of when I think of clinical utility of the T&M classification system. Classification is maintained jointly by the American Joint Committee on Cancer, AJCC, and also maintained by the International Union for Cancer Control, the UICC. So the changes to classification is done jointly. But one of the things I need to caution you is that the application of the TNM classification is slightly different in AJCC and UICC. So it's just one of those points to consider, especially if you're trying to find information, by Googling and you see something from UICC or the European community. The application may be slightly different, so just kind of keep that in mind. Information is updated every 6 to 8 years, and when this occurs, as we all know, in response to new clinical data and really a new understanding of the biology or better understanding of the biology of tumor, as well as a better understanding of factors that affect outcome and treatment. And the updates are limited to really every 6 or 8 years for a few reasons. One, you need 6 or 8 years to really ensure that the science, that the clinical data supports a change in the protocol. So that time frame gives AJCC and the UICC enough time to really ensure that data is available. And then the other thing is that when you make changes to TNM classification, that makes it difficult to really compare outcomes in groups of patients. So when you change that, you basically, to some degree, the ability to compare it to previous groups. So that's, those changes are limited to every 6 or 8 years. Next edition of the AJCC staging manual, I believe, is coming out in 2016. So it's about 6 or 7 years after the release of the 7th edition. And to talk about before we move on is really a clarification on terminology. And I throw this out there because I have the same issue when I look at the terminology. What is it they're talking about? And there's several phrases. If you look at the AJCC staging manual, at the CAP cancer protocols, any of the literature, you'll see interchangeably they talk about classification, category, staging, stage grouping, and grouping. And so what I was kind of separate out a little bit of the terminology. When we talk about stage grouping or staging, that's really talking about the anotypic stage or prognostic group. So we're talking about, for example, PTNM, CTNM, stage 2, stage 3. So it's kind of the complete thing. We're talking about the individual pathologic classification, the T classification, N classification, or M classification. The term you use, category or classification for that. So like I said, you'll still see all these terms used interchangeably, but that's really kind of the definition of those phrases there. What I'm going to move on to is just the general rules for pathologic staging. And once again, as pathologists, we're going to focus on the pathologic staging as opposed to the clinical staging. But ahead of that, there's both clinical and pathologic staging that needs to occur for every tumor, and so I really think of this as really a dual system of staging. We do provide some information for the clinical staging, but really our focus is the pathologic staging, ensure that there's enough information that we provide the appropriate information for the pathologic classification of T and pathologic classification of N and M if appropriate. And so, talk about pathologic staging. You what type of information needs to go into that primary or that initial pathologic staging. What is pathologic staging? Well, pathologic staging is basically all the pathologic information that is collected up to the point of definitive treatment. And so far, we're talking about definitive surgery in these cases. And AJCC defines the information that can be used for pathologic staging is all the data obtained through definitive treatment, and like I said, definitive surgical procedures, usually what we're thinking, or within 4 months of diagnosis as long as there's no progression of disease. And the reason that in there is that we know cases where they start, watchful waiting surveillance, and then 3 months down the road, the patient's in their mind and they decide to have surgery. And so your definitive specimen is not till 3.5 months into their diagnosis. You can still use that information for that initial or primary pathologic stage. Clinical stage is a little bit different. Like I said, we're typically not involved in clinical staging to any significant degree, but I'll put out exactly what the time interval is for clinical staging. Clinical staging really refers to all the information that's collected from the time that they were initially seen for the cancer to the time of definitive treatment. So that when there, it's radiologic studies, laboratory studies, biopsy results, radiographic studies, everything would be included for that. At the time of definitive treatment, the clinical stage is determined, and there's no longer any additional information that's used to affect that clinical stage. And once again, they also have a 4-month window as long as no progression occurs during that time. So I wanted, as a general rule, is that as pathologists, the X designator makes a case unstageable. Now, it doesn't necessarily mean it's appropriate to use an X. It just means that when we look at a tumor, and especially if it's over multiple surgeries, we need to make sure that the information is used appropriately, and that an X designator is not used inappropriately. For example, calling something PT2NX when there's enough information to do the pathologic classification for N. So like I said, there are lots of situations in which the X designator is appropriate when it comes to pathologic staging, but we need to make sure that we don't inappropriately use that X. Another rule is that if there's uncertainty with either the pathologic classification of T or N, then we assign the lower PT or PN. A good example of that is occasionally on a colorectal tumor, you have difficulty determining whether or not it extends into subserosal soft tissue. When out, you assign the lower PT or PN. When non-anatomic factors are used for staging, those non-anatomic factors are absent, you assign the less advanced stage. So this applies to the stage grouping. Most don't do stage grouping as a part of our pathology report, but I just want to let you know that that's also one of the things that if it's not available, assign the less advanced stage. And I think we're aware of this as practicing pathologists. Certain tumors of the same organ, you stage, you do the pathologic classification of T by the most advanced. For metachronous tumors in paired organs, or for metachronous tumors, you stage report separately. So you report those as separate tumors, and I think most of us are pretty comfortable with that. What about next are the specific rules for the pathologic classification of T, N, and M. And so let's start out with T. Let's start out with the pathologic classification for tumor. And the first thing is that usually PT is assigned on resection, and generally not on biopsy. We can assign it on biopsy only if the highest T category can be assessed. And so you think about it, once again, you go back to the colon, you're not going to see a biopsy in which you can assess the highest T category. With breast carcinoma, in which it's basically the size of the tumor that determines category, you may be able to assign a T category based on the biopsy. One of the challenges I see with that, though, is that for the most part, in the T category, which assigns the T category based on the size of a lesion, oftentimes T4 is based on extension into an adjacent organ or in soft tissue adjacent to the organ or whatever. And so the question is whether or not, when you look at biopsy, whether or not you're comfortable that there's no evidence of direct extension into adjacent organ or into the adjacent soft tissue. So like I said, that's a little bit of a judgment call there. But I think for the most part, with a breast biopsy in which they remove the entire tumor, based on a mammatome biopsy, you should be able to assign a PT based on that. And then one of the things that AJCC emphasizes is that when you have multiple specimens, you need to make a reasonable estimate for PT. So once again, if we're talking about a melanoma in which there's an incisional biopsy or God forbid a shave biopsy, there's the re-excision, there's the sentinel node and whatever else. You need to make a reasonable estimate on the PT, even if you're having a hard time determining the depth of invasion because it extends from the original biopsy into the definitive excision and things like that. In this instance, calling it PTX because it crosses into multiple specimens or it's a fragmented specimen or something like that. Calling it PTX is not helpful and it doesn't help the patient. So in some cases you have to make a reasonable estimate in terms of size or depth of invasion, even if it's across multiple biopsies or in a fragmented specimen. For pathologic classification of lymph nodes, coming up a little slow, sorry about that. Pathologic classification of lymph nodes, there are a few things. And in general, it's difficult to assign a PN classification if there has not been a pathologic classification for the tumor itself. So if you have a PTX assigned, you generally can assign a PN, and so that's kind of a general rule, and we'll talk a little bit about that. So let's go back to the colon carcinoma, and all of us know that minimum number of lymph nodes required to adequately assess a colon section, or it's considered part of an adequate colon resection, is a minimum of 12 lymph nodes, and we've all been there where we've found 2 lymph nodes. So the question is do you call that PNX or do you call that PN0 if those 2 lymph nodes are negative? As long as the tumor is fully evaluated and you can assign a PT, so a P2, for example, you can assign a PN. So it can be P0, or if there's a node involved, a PN1. So minimum number of nodes need to be evaluated to determine PN if you can determine the PT. And that's one of the general rules that you kind of need to keep in mind. When you have a PT, when PT is not evaluated, you shouldn't, in general, assign a PN on a biopsy node. As a CN or don't say anything in the report. The only exception is when the highest N is evaluated. And so I think a good example of that is, think of the melanoma on the lower extremity, and we have matted nodes in the groin. If you evaluate the melanoma, you do a small incisional biopsy on the excisional biopsy in the melanoma, but not the definitive treatment, and then move the matted nodes, and the matted nodes are full of packed with melanoma. That is actually an N3, so that you could assign that as a PN3, although you wouldn't be able to assign the PT because you haven't done the definitive procedure. So it's an example of when you can evaluate the highest N, and you can apply the pathologic classification for N without the pathologic classification for the tumor. And this is when the primary is unknown. You can assign the pathologic classification for N with a biopsy node. Now, having said that, the limitation here is many times we don't know that the primary is unknown. Okay, we may get a lymph node, and we may hear that they haven't found a primary yet, but we also know that they haven't searched. So just kind of keep that in mind when when documenting that in your pathology report. Another pathologic classification of PN is that a direct extension of tumor into a regional node is considered positive. So that is that's actually straight out of the AJCC manual, and I've seen a number of people who would not consider that positive, but in fact it is. And so one of those general rules to keep in mind. And then and I put this out there because I hear this a lot. I hear this a lot in my practice, and I talk to people is not necessarily completely understanding the difference between regional and distant lymph nodes. So, I think most of us who've been in practice for a while have a full grasp of this concept. And one of the things that I tell our residents to do is go back to the CAP protocol or go back to the AJCC staging manual and take a look. They actually identify what's in a regional, considered regional lymph node and what's considered distant lymph node. Since distant lymph nodes are considered metastatic disease if they're involved, whereas regional nodes are considered nodal disease. So classification, that's what we're going to talk about next. Comes on the slide here. So metastatic disease, so PM. A couple of rules here, and those of us who've been around for a while are having previously used MX as a term. When we classify, the fact is no longer used, and you shouldn't use it. So you shouldn't call something PMX. So, for example, you may call it PT2N1, and if an M has not been evaluated and it's not positive, then you should just not even include the M classification in your stage grouping. But generally omitted from the pathologic staging unless metastatic disease is identified with tissue confirmation. With that in mind, when you receive a biopsy of a clinically suspicious node, mass or tissue lesion or distant node, and it's negative, so it's not involved with tumor, you do not classify that as PM0. That's not considered enough to be able to do the pathologic classification for the absence of metastatic disease. So kind of keep in mind that PM0 is not in our lexicon anymore. And PM0 technically can only be assigned at autopsy. So, since most of us don't stage at autopsy, just kind of consider PM0 as to not be in our toolbox anymore. And then emphasize this enough. Understand the difference between regional and distal lymph node, distant lymph node categories, and refer back to the AJCC staging manual or the CAP calls to really determine whether or not you're dealing with a regional or distant node. And so, at least in my practice and in my career, if you get a definitive resection, all the nodes associated with that are typically considered regional nodes. Distant nodes tend to be sent as separate containers, so usually you have a pretty good idea what's considered a distant node and a regional node. But once again, refer back to the CAP cancer protocols or the staging manual. Talk about staging tumors. There really are five categories for staging tumors, and so the two big ones are the clinical and the pathologic, as we talked about earlier. Clinical really refers to pre-treatment, and we'll talk about that a little bit, in addition to what we've already talked about. And then the pathologic, we think of our primary pathologic staging or primary pathologic classification, which we talked about. But more and more with cases now, we don't get the definitive resection specimen until they through neoadjuvant chemotherapy or neoadjuvant therapy. And a good example is rectal carcinoma. That's probably the classic example. So really, when we talk about pathologic classification, you really have to keep that primary pathologic classification or staging in mind, as well as that's seen after neoadjuvant therapy. We'll talk about each of those. Then the categories. We can classify based on, with retreatment and people who have had recurrent or progressive disease, and we'll talk about that a little bit. and then we'll spend about 10 seconds on classifying or categorizing with autopsy. The first thing we'll talk about is clinical or pre-treatment, and so with the clinical or pre-treatment category, the modifiers C, so you see TNM or TNM without the C, that refers to the clinical stage. So just make sure everybody's on the same sheet of music with that. And what they use that for, what the oncologists use that for, is to really define initial therapy, and also used to some degree for population comparison. So really the main goal here is to initial therapy based on the initial TNM. And this clinical stage grouping is applied. So it's a stage 1, stage 2, whatever. And so this is assigned and kept as a part of the permanent record. Your primary pathologic staging, the term we use, so the modifier we use is the P, so it's PNM is typically how we think of it. And when you look at how AJCC defines the pathologic stage, it's based on the definitive surgical therapy. And so keep that in mind as we talk about the cancer protocols. What it does is it provides accurate prognostic information for patient care, and so that's really one of the big functions of the pathologic staging. And so pathologic stage grouping, that is, stage 1, 2, 3, or 4, is applied to this. I think most of us as pathologists do not do the stage grouping in our reports. We leave that for tumor board and for the tumor registrars. And we're seeing this more and more, obviously, over the last decade plus. Neotherapy applied, and so we end up not seeing it, seeing the specimen, and obviously, till the definitive resection is not done till after therapy is given. And one thing you want to do is not age this in such a way that you confuse it with the pathologic stage. And so using the right modifiers is important. And so clinical modifier is YC, so you put that in front of the TNM, or as what we use is YP. So you get another resection for something, and you can stage it or classify at least the T. You would say PT or YPT and or whatever. But it's important that you have the YP modifier in front of it. And clinically, what they use this for is to identify response to therapy, and it helps define subsequent therapy as well in these patients. Like I said, we typically don't do stage grouping, but if we do, you want to make sure that the stage grouping nomenclature identifies it as basic therapy. So you would stage YP1 or stage YP2, and the reason is think of the rectal carcinoma. If they had neoadjuvant therapy, no residual disease. So their clinical stage was a stage 3, for example, and their post-therapy stage is a stage YP0, or YP1, let's say, if there's some residual tumor. That makes a difference if you inadvertently note that as being the pathologic stage as opposed to the post-therapy stage. So keep in mind with using the appropriate modifiers. Retreatment is used for retreatment staging. Actually, it should be retreatment classification is a better term. Is used for recurrence or progression, and generally this is by our clinical colleagues when the treatment is planned after a disease-free interval. But it can be used for a progression in which they don't have a disease-free interval. But that's generally when it's used. And the modifier is an R, and it's an RP. And again, this is important to be able to differentiate it from other categories of staging that we use. And it's generally used to to find further treatment, especially in the setting of recurrence after disease-free survival. And the category is autopsy, and the modifier here is a small a. And, one of the things to note is that we don't use the AT&M classification for autopsies on people that we do who were diagnosed pre-mortem and went through when they went through treatment or ended up not going through treatment or whatever. AT&M is only used when cancer is not evident prior to death. So that's a limited use for autopsy. And then one other staging category, and I put this in big quotes, because this is the working stage. The working stage is typically what we think of, that the discussion revolves around in tumor board, in that it's basically used for planning purposes prior to the pathologic stage. So the working stage may look a lot like the clinical stage and may actually be the clinical stage, but oftentimes it'll incorporate information that's really considered outside the realm of the clinical stage. And another way to think of it is it's a mixed stage group for treatment planning, and it combines both clinical and pathologic information. And a good example of this is resection of a breast carcinoma without the sentinel node being yet. So, you don't have enough information for the pathologic stage, and probably too much information for the clinical stage because you've already done that definitive resection. Going with the protocols, that's our next topic here. In terms of a general overview of the cancer protocols, we're familiar with these, and really the goal behind protocols and the use of the cancer protocols is to structure reporting in a way that improves the quality of patient care. And that's really kind of the big picture goal of applying cancer protocols, and that's what I always kind of keep in mind in my practice when applying these, and I keep that in mind when people have recommendations on how to apply cancer protocols. So, first thing we'll talk about are the components of the cancer protocol, and we always think of the checklist, the cancer checklist. The actual term is case summary. We don't use the term checklist there, but it's there in the popular lexicon, so we still kind of think of it in those terms. And cancer, or the case summary of the checklist, really is comprised of the use of a synoptic format. So one of the things that's out there in the popular lexicon is that we use the term synoptic report, meaning that a cancer protocol, the checklist was applied to a specific tumor. We call it synoptic report. Synoptic report consists of a synoptic format, which is really paired elements of data elements and the response on individual lines. It's simple as that, and it's structured in such a way that it minimizes confusion and hopefully doesn't bury information. That's why the synoptic format is considered one of the requirements using the cancer protocol. With the checklist or summary, there's the required data elements and the optional data elements, and the difference between these is the required data elements. Every time you're required to apply a case or checklist to a tumor, you have all the required data elements, even if they're not applicable. And part of that is to ensure that your clinical colleagues understand that you look for those. So you look for that lymphovascular invasion, even if it's not there. You look for lymph nodes, even if you didn't find any, something like that. Optional data elements are exactly that, and sometimes that is based on the organizational requirements in terms of data collection, and does reflect the preferences of your oncologist that you serve. And of course, pathologic classification is a requirement of the checklist. So T&M, and basically what you want to do is all the available information up to that date to be able to to PTM classification. And so it may not be on that specific specimen. It may be on the biopsy or separate biopsy or whatever. But you want to apply that information. You want to look at the pathologic classification as being a composite of all the pathology information that was provided up to this use of this checklist. One of the things that I find that I actually love about the cancer protocols are the explanatory notes, and I use those more often than I actually use the checklist. The explanatory notes are exactly that. They explain all the various elements within the checklist or within the case summary, and actually provide in terms of grossing specimens, determining margin status, and things like that. And the explanatory notes are evidence-based, so it's a pretty good way to quickly look at to see, okay, how do I determine a margin status on this? How do I submit the specimen to really evaluate margins and so on? So I find the explanatory notes to be extremely helpful and probably one of the most useful things from cancer protocols. One of the things that they do, as I said, it provides structured reporting, and it standardizes terminology. And so most of the protocols use the WHO terminology for malignancies, and it's a terminology that's also used by the staging manual as well. And then terminology for tumor sites as well as procedures are based on the ICDO terminology. So one of the strengths of the cancer protocols are the fact that it standardizes the terminology. So as we talk a little bit about how to apply these, one of the things to always keep in mind is even if you don't have to use the cancer protocol for something, think about the opportunity to standardize terminology with protocols. So standardizing it using the WHO terminology for malignancies and the ICDO terminology for tumor sites. So when do we use when is it required what is required to be used? When are the cancer protocols required to be used? And this is defined by two different things. One, the CAP laboratory program, so the accreditation, laboratory program accreditation basically defines to some degree the use of the protocols, although I think it's pretty general. Probably more important is for hospitals that are American College of Surgeons Commission on Cancer accredited. There are requirements that are outlining for that. So requirements for the use of the cancer protocols are based on those two sources. And there's only two instances in which you're required based on those by CAP and ACS. One on definitive resection specimens. So once again, think back to kind of the topic of what we're talking about today. We're talking about multiple surgeries as a part of their initial care for their cancer. So you don't necessarily need to use a cancer protocol for all of those, but you need to do it on the definitive resection. And a list of biopsies in which certain biopsy specimens in which you need to apply the CAP cancer protocol, and that's on the CAP website, and so you can look at that. One of those are prostate biopsies, but there are also some other biopsies as well. That's how the protocols are revised, but how to use the protocols outside of the minimum requirements of doing it for definitive specimen or definitive resections and the occasional biopsy in which needs to be used. Really, the use of these is really an organizational decision, and I said that an organization or healthcare system really needs to look at the opportunities for improved care through standardized reporting and terminology, and opportunities. And remember, we use this information for more than just patient care. There are reporting requirements through tumor registries and things like that. And so what are the opportunities to be able to standardize that terminology and data collection for cancer reporting and surveillance? So really, the use of this is twofold. And so how it is appropriately used is really an organizational decision. And one of the things I emphasize is the minimum requirement is to use it for definitive resection specimens. I think the optimal use is really much broader than that. And so I look at the opportunity to apply synoptic format to other resections other than the definitive resection, and probably more importantly, applying standardized terminology, using the WHO terminology, the ICDO terminology, in line with the cancer protocols, and using it not only for the definitive resection, but the biopsy specimens, the resection for margins, the resection of the node, recurrent disease, all of that. So like I said, this is an organizational decision, but I think there's a lot of opportunity to really improve care through the standardization of reporting, standardization of terminology. So I encourage organizations to really look beyond just the minimum requirements for use of the cancer protocols. So protocols, as most of you know, are they're written and managed by the CAP Cancer Committee, and there are, I think, about 68 or 69 of them right now, and they do get revised every few years. And so one of the things that we're doing as the Cancer Committee now is we're really applying level of medical evidence for cancer protocol. We want to ensure that the record data elements, the ones that we think need to be reported, are truly supported by medical evidence, and not just by someone's kind of pet whim or based on the desire to collect that for research purposes or whatever. So the CAP protocols are now being levels of medical evidence are now being strictly applied to the CAP protocols as they're being revised, and they're being revised. It's a pretty extensive process. It takes a good year to do, and part of it is that there's a multidisciplinary panel that's put together that includes not only academic pathologists and other physicians, but also those in the community setting. We as a committee have to think of who our stakeholders are, and ensure that what we put together is really applicable to our stakeholders. The second part of that is we do put it out for public comment, and we do review and act on public comment. So each of these under a pretty thorough review process before it's published. And so for the last few years, all of them have undergone this process where they've applied levels of evidence to what are considered to be required data elements versus optional, and they're undergone an extensive panel review as well as public comment. And I think all that together really makes for a stronger and more usable care protocol. Actually, before we go on to the slide, there was actually one thing I wanted to kind of. I'll wait a few minutes for this. So we're talking stage procedures today, or multiple surgeries, and so the examples we think of in melanoma, you'll have the initial excision followed by definitive resection and sentinel node, and that could be 3 procedures right there. When you re-excise margins, that could be a 4th procedure. Breast, you could do a core biopsy followed by a lumpectomy and sentinel node. You could have multiple resections for additional margins. Ultimately, a simple mastectomy on top of that. So lots of opportunity, I think, for having one tumor in which there's multiple surgeries. There's the definitive surgery followed by re-excision for margins, metastasis, things like that, and then the surgery followed by later surgery, 6, 8, 10 months later for progression or recurrence of disease. So a lot of opportunities here, and so how do you apply the CAP protocols to these? So one of these is really kind of defining the challenges that we see with multi-stage resections or stage sections. And one of them, and once again, go back and think about the rules that we talked about with classification, and kind of apply these as you think about these in terms of stage procedures. Once again, determining the definitive tumor size or depth of invasion, so the critical components of the pathologic classification for the tumor, so the PT. Calling something PTX because it's fragmented or it's across multiple biopsies is helpful and probably not appropriate. So you need to understand what are the general rules for determining PT. And sometimes we know all about margin status. What constitutes a thorough evaluation of margin status. What do you do when they have to keep realizing margins? How do you determine the final margin status? Things like that. That's one of the challenges that we deal with. Not necessarily with the TNM classification of it, though. And then one of the things, and this is more of a technical challenge, we understand that disruption of lymphatic drainage, if they do an excisional biopsy of a breast carcinoma, and then do the sentinel node at a later date. So how accurate is that our sentinel nodes in that setting? And just once again, one of those technical challenges. So we can provide an answer on. And then the challenges with reporting of stage procedures. And I look at this in a few ways. When do we use the cancer protocols? And so I always kind of keep in mind what the minimum requirements are for the cancer protocols, and what the optimum use of those are. Talk about stage procedures. How do we use the cancer protocols in that regard? Once again, think about what the minimum requirement is, which is to use cancer protocol on the definitive procedure. You tend to have information from, in a stage procedure or multiple surgeries, you tend to have information from multiple sources there. And you always have to think of that definitive procedure, that checklist, that the synoptic report that you put out for that, as really being kind of the composite, the synthesis of all that information from the previous specimens. Same thing when you talk about using cancer protocols when there are multiple surgeries, that are across that initial episode of care. For example, recurrent disease down the road. Do you use the cancer protocol for recurrent disease, for example? And so those are all things to think about as you apply these. So when I look at these challenges, I go back to kind of the basic rules for TNM classification, as well as use of the cancer protocols. I move on to the snares. I just kind of wanted to present a few take-home points. I don't have a slide for this, but we talked about take-home points for applying the cancer protocols and TNM classification to stage procedures and multiple surgeries. Other rules for TNM classification to minimize the use of the X designation, and I think I'd rephrase that to basically eliminate the inappropriate use of the X designation. So it is oftentimes in surgical procedure very appropriate to pathologic stage something as to give the pathologic stage as P2NX. For example, thyroid carcinoma. How often do we see nodes in thyroid carcinoma? Nodal section is not part of a thyroidectomy for carcinoma. So P2NX is an appropriate pathologic stage. When the pathologic classification for tumor, that is PT, know when you can use the information of biopsy to determine PT. That's one of the general rules. And then understand that you really need to determine a PT, even if it's across multiple specimens or surgeries, or you have limitations like fragmentation and things like that. So once again, in that setting, calling something a PTX is probably not appropriate. Pathologic classification of nodes. Understand the rules for the pathologic classification of nodes as we laid out in terms of, of the PT status. Know staging categories and when to use, and once again, it's important to be able to use the right modifiers so that there's no confusion between, the pathologic stage and recurrent disease, or if there was neoadjuvant therapy, so that the tumor registrars do not confuse that with the pathologic stage. Because remember, that pathologic stage is what's used for prognostic information. When I'm on multiple specimens, once again, think of your job in determining a pathologic stage. Think of it as determining a composite pathologic stage. So you're using information from perhaps multiple specimens to be able to determine the pathologic stage at the time of definitive resection. And then once again, understand the rules for applying the CAP cancer protocols as we talked about. We talked about the minimum requirement of doing it for the definitive resection. So what that's telling you is you don't have to use it for all the other things. You don't have to use it when when they re-excise margins, do a lymph node, for recurrent disease, or anything like that. But also think about when is it best for patient care. When is it best to apply CAP protocols in other settings in which it's not used. And if you don't want to take it that far, when does it improve patient care, appropriate for patient care to standardize things like terminology, applying the synoptic format, things like that. So they're really kind of my take-home points on this. And so what we'll do is we'll move into two scenarios. And once again, these scenarios were provided to me by Demo too. These were actual scenarios in which we asked some questions, and so we'll go through these. And the first one is a 62-year-old male who underwent a subtotal gastrectomy after neoadjuvant treatment for recently diagnosed gastric carcinoma. Pathology: poorly differentiated gastric carcinoma, 3 of 34 nodes involved, 1 serosal deposit, marker negative, and so its stage is a PT4A N2M1. Underwent postoperative chemoradiation therapy. Thirteen months later, the patient developed a large recurrent tumor at the anastomotic site and underwent completion gastrectomy. It's a poorly differentiated gastric adenocarcinoma invading the muscularis propria and fat with focal direct extension liver, that is RPT4B, 3 lymph nodes positive, viable tumor and 2 omental nodules, and the resection margins clear. The endoscopic description of the findings was issued and did not issue a synoptic report, so the CAP cancer protocol was not used. So, classification correct. Remember, it was classified twice. Okay, so with the initial resection, it was classified as a PT4AN2M1. Remember, though, that this patient had neoadjuvant chemotherapy, and this is one of those key points in terms of using the appropriate modifier. So it should be a YP4AN2M1. So we're using the YP instead of P. It was staged appropriately, and the appropriate modifier was used. So RPT4BN2. And so once again, we typically don't assign stage 1, 2, 3 with pathologic classification, but remember, with recurrence they do not assign a stage. They'll do the classification and they'll do the TNM stage part of it, but they won't apply a stage group to it. Second question is, should a synoptic report be issued for the second resection? And so once again, think back to what we talked about in terms of what are the requirements by CAP. And so what are the requirements if you're COC accredited? What are the requirements? What is the COC inspector going to look for? And so CAP requires that a synoptic report be issued for definitive resection only. So that's definitive resection that is used to determine the primary pathologic classification. So we're talking about recurrent disease, and they do a resection, completing gastrectomy at this point. You have to issue a synoptic report for that. And once again, this is Baker's opinion. I think it's very good practice to issue synoptic reports for resection specimens, even if it's not the definitive section. But having said that, it's not a requirement, and so or whatever your organization feels is necessary is probably the appropriate way to do that. Cholecystectomy with transmural defect at the liver bed, and a synoptic report was issued identifying this as adenocarcinoma, PTUNX. A second procedure was performed soon after, in which there was gallbladder bed excision, including a small portion of liver. And so the pathology on that was that there was residual adenocarcinoma within the soft tissue, no liver involvement, social involvement present. So this was consistent with a PT3. Those were positive, and lymphovascular invasion was noted. So the question posed to us, we'll see if that comes up. Should the first synoptic report be updated to PT3N1, or should a second synoptic report be issued or report as a narrative? So once again, it goes back to the discussion of which of these two procedures is considered the definitive. If you're going to stick to the strict requirements of use of the protocols. And some people might disagree with me on this, but this is my read on it, is that the initial procedure was not the definitive procedure. It wasn't done in order to of his cancer, or at least a stage. This is not the definitive procedure. The initial surgery number one, does not reflect the final pathologic stage. So we do that already. It needs to be upstaged. And so what I would do is I would do a synoptic report for the second or definitive surgery. And really, the synoptic report for the definitive surgery should reflect the final pathologic grouping or staging, so PT3N1. And then recommend clarification to the first report regarding TNM classification. So rather than updating that first one, I mean, you can always, I suppose, amend it, but I would put some sort of clarification of that first report regarding the TNM classification. But I believe that the second specimen is truly the definitive procedure, and so that's the one that needs to be done in synoptic format, and also needs to report the final pathologic grouping or staging. Okay, questions?
Thanks, Tom. That was great. So, any questions being posted yet?
Yeah, I think there's one. I'm just getting to it. Okay, this is a question from Dr. Lee Wianarco. A patient that had previous chemorad, and there is no residual found. Is this considered a PT0?
So the question is chemo. So I think they're talking about neoadjuvant therapy. So if we're talking about the primary pathologic stage, include all the information that's accumulated up to the definitive procedure. So if somebody, so they shouldn't have had adjuvant chemotherapy before that. So it sounds like they're talking about neoadjuvant chemotherapy, and so in this case, the the classification would be based on IP and then TNM. So there's no residual tumor. The stage grouping would be a stage YP0. So in that case, answer the question.
Okay, no follow-up, so.
Okay.
I'm
Hopefully that was clear.
Yeah. We haven't any new questions.
I have a question, Tom.
Yes.
For melanoma, in Ontario, the melanomas are sort of done in doctor's offices. They get signed out in the private labs, and sometimes we don't have even the reports or as to what the PT stage is for an excisional biopsy of melanoma. And in the hospital setting, we get the re-excision with sentinel lymph nodes. What happens if you've got a little bit of residual melanoma or microsatellite focus or an in-transit met? That would then be considered that the re-excision with the sentinel lymph nodes would be considered the definitive surgery, right? But you may.
Yeah, Demo, I would consider that the definitive procedure, and so boy, that's unfortunate if sometimes you don't have the information on the biopsy, because that'll really determine the depth of invasion. Yeah, that's unfortunate. Do you all require the initial biopsy when a patient goes somewhere for treatment, and the biopsy was done elsewhere? Do you all require the biopsy as a part of your hospital policy, hospital procedure before procedures done to verify the diagnosis and so on?
No, because we just get the re-excision on the sentinel lymph nodes, so we don't even know that the patient is coming. At least from the lab perspective. Yeah, I guess where we struggle sometimes is excision on the sentinel lymph nodes are absolutely negative, in which case then it's still considered a definitive surgery, but you don't use the Y. You obviously can't use the the PT0, and now you can use the PTX, but you can use the PA0. So would you still use a synoptic report not knowing what the initial melanoma showed, or Yeah,
great question. So when initial melanoma is cut out somewhere else, and you don't have access to the information, I'm not sure that it was appropriately excised in order for you to determine the PT. So the question is whether you can do a PN at that point. That's a great question. I think what I would do in that case is I would probably I would not do a PN in that case unless you're reasonably comfortable that have a report that says the PT was done and that you can determine that. But if you don't have evidence of that, I think I would just put in a comment that you not determine the PN because it has not undergone a classification for the T. I think that's the way I would handle that. That's a tricky one.
And would you use if you've had a previous surgery done somewhere else and you actually do have the information and you do the slides, and then you have the second but definitive surgery, can you actually do a conglomerate report actually using the initial procedure information and include it in the second definitive surgery perspective? So can you sort of merge those two into the final? Is that technique can you do?
Yeah, I actually encourage that. So my thought once again with the definitive resection, and so you're in a little bit of a different situation in which a lot of times the biopsy is done in the clinic, and definitive procedure is done in the hospital setting. So so sometimes all you have is the pathology report, or if you're lucky, they'll send you the slides. But in terms of patient care, I think it's always best to set the opportunity for that definitive resection to really to reflect that entire episode of care. And so I would either incorporate the data that you're getting from an outside report, or actually issue, a part of your report. I would issue that in your synoptic report for your definitive resection, so that information's there. That's what we do in practice, and I think it provides good information for patient care. I would definitely use that in terms of the stage grouping. So the PT&M classification, I would definitely use that information on the prior biopsy as well.
We've got a couple more questions that have come in.
Sure.
One is from Dr. Russell Price in the Victoria Hospital in Barrie, and he asks, what about an initial breast lumpectomy for invasive cancer with positive margins for DCIS, followed by re-excision of the lumpectomy site, showing a bit of DCIS but clear margins? Is second synoptic?
Sounds like a synoptic report was issued on the first one. Is that correct? I think that's what he's saying. So margin status, so DCIS and margin status are part of the required elements for invasive breast carcinoma. So at that point there needs to be a definitive that reflects the definitive resection. I think you have a couple of options there. One is you can go back and amend the lumpectomy report to no margin status, the re-excision of margins, or you can consider the margin resection to be the definitive procedure. It's kind of a backward way of thinking of it, and issue a synoptic report for that. But I think at some point in that episode of care, you're obligated to provide a synoptic report, clinical care that encompasses all of the appropriate elements and allows for appropriate pathologic classification. So kind of thinking this through, I think I would just probably addend the initial lumpectomy and add margin status. That I think that's what I would do. There's no right answer to that. You can either way on that.
Thank you. I've got another question from Dr. Dae Tong Kim. He asks, in the first scenario, I think M1 was mentioned, but I do not recollect a description of it in the presentation. Was there one? If so, would it be a simple explanation, or can you help me to recall that?
Yeah, I think it was the serosal deposits. In the first scenario, I believe there were serosal deposits as they were described, and so I think that's what was being considered metastatic disease. I don't know what serosal deposits were. With the information I had, that's what I determined, or based on that.
Okay, great. There's no more questions that have come in. No, and Dr. Kim says thanks. That's great. But we haven't got any more questions that have come in the meantime.
Tom, just I think a presentation would actually be a really good, almost, if anyone has got for pathologists, in their departments, the information you provided, I think, provides some very nice guidelines and approaches, and maybe that's something we would consider as actually taking the information you provided and somehow including that into a pathologist manual, because it provided, I think, some very principles on which to work on. So
I think that's a great idea, Demo. I do. So we'll consider it as we move forward with some of this stuff.
I don't.
There are no more questions.
That's a great idea, Demo.
That was excellent because you know we always struggle with that, and I think it was just excellent. So Tom, so if there's I guess no more questions, Dana, should we wrap it up, or should we just wait a few more minutes, or any additional comments from Tom, or?
We can wrap it up from this end unless Dr. Baker has anything he'd like to say.
No, well, I appreciate you inviting me to talk about this. And like I said, this is something that oftentimes there's no right answer. You know, as we discuss some of these scenarios, you know, so it really is going back and applying just the general rules and thinking through these things, and then applying these things in a way that you know. Apply common sense when it comes to patient care. You know, what is the way that's going to really you know, going to benefit the patient, and so that's kind of what I keep in mind with that. Like I said, no right answer, and we even on the CAP Cancer Committee, we oftentimes struggle with some of these questions, you know, because these are things we haven't thought about. And so how do you apply the general rules to this and come up with a solution that moves forward? And thank you very much. I appreciate you inviting me to discuss this.
I have some closing remarks. So I just want to say on behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I would like to thank Colonel Thomas Baker for a truly comprehensive, informative, and very clear presentation today. This is the second session of the 2014 series of CAP checklist presentations. Actually, I think it's the third one. And we would welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluations. And once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted via Cancer Care Ontario, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for continuing education credits, and please see your session notice for more information. And again, note the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation dates, and the sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be issued for 1 month. As a reminder, our next session is on March 27th, and it's sarcoma in the community and centralized settings, and that'll be Dr. Rita Kandel. Again, Tom, thank you very much.
Well, thank you, Dimo.